you so much. I hope you've enjoyed it. I hope the dessert's been good. Feel free to continue and take a washroom break if you need to. But we're going to get started with the final and I hope most exciting part of our first day here together, and that is to welcome some guests with us today and to talk all about virtual care for the next hour or so. And we're going to, of course, build in lots of time for your questions as well. So, I mean, starting to talk about virtual care, we know that it means many things to many people, depending on where you live, where you come from, whether you are attached, and of course what your needs are with regards to the primary care system and how often you need to access it. Some of the themes that have already come up, I think, in our discussions here that will be kind of relevant tonight as well, it includes how do virtual services play a role in sustaining and improving delivery of care services, especially in rural, remote communities where a lot of us are coming from, helping us overcome the shortages and resource constraints that we have in the system now, including the attachment crisis, and of course, leveraging technology, the data out there in the field, and of course that leads us to some of the concerns that have been raised, where we want to make sure that virtual services are part of a robust accountability system. Of course, we've already had a lot of people bring up concerns around data, information, both in terms of sharing, in terms of privacy, in terms of access, all around. And then, of course, ensuring that, as we have talked about a lot here, that any innovation, any delivery of primary care services kind of sustains that quality of care from the 4 C's that we talked about, the continuity of care, the coordination of care, comprehensive, and of course the contact. And so we want to understand a little bit better tonight how virtual services are doing in the primary care system, and of course where they can do better, what they can be a part of it. And ultimately we'll be looking for some guidance from our guests here on the kind of steps and things we consider. And of course, very importantly too, what are the obstacles and what are the barriers in our way to actually doing this? So I'm going to introduce our 4 wonderful speakers. We have Gladys. Gladys, if you're with us, we'd love you to turn on your camera right now. Gladys Mitchell, are you there? There she is. Hi, Gladys. Gladys is a member of the Saik'uz First Nation, living in the community of Stellat'en near Vanderhoof. And she's also, I think, remarkably to have. She's the granddaughter of Mary Todd, perhaps better known as Stony Creek Woman, if you're familiar with the book and the story. So we're delighted to have her, and she's actually joining us tonight from Las Vegas on vacation in a hotel room. So welcome again, Gladys. Thank you for giving us a little bit of your vacation time. And we'll get back to you in just 1 second. And then sitting next to me here, I have Birinder Narang, clinical assistant professor at UBC and a family physician with the Reach Community Health Center, and who's just became a father for the first time. Congratulations. The due date was supposed to be tonight, but thankfully the young one came early. Last week, so he's fully
so we're good now, we're back to work.
Joins us tonight, back to work, exactly. Next to him we have Keir Peterson, the Chief Medical Officer of Telus Health, of course a very big presence in virtual care delivery here in BC. He's also a former emergency room doctor, right? And you've been on the front lines and seen a lot of the overall general state of our care systems here and have been a part of a lot of challenges, I understand. And we have Lindsay Hedden as well, joining us from right here at SFU, assistant clinical professor at UBC, family physician. Oh, sorry, that's my bad. I was reading this in reverse order. Assistant professor of health services
like a Freaky Friday
at SFU, and who runs a lab that, of course, studies a lot of transformation in this field. And I think you've also seen quite a lot of the experience there as well. Gladys, I'm going to invite you to get us started here. You've told me a little bit about how virtual primary care is being delivered in your community, and I know that you had a story you wanted to share with us, a bit of a success story of how you see primary care delivery through virtual services working really well in your community. Can I invite you to share with us now, please?
Hi there. I actually just want to make a couple of little corrections. I am the granddaughter of Stony Creek Woman. Her name is Mary John.
Mary John, excuse me.
Yeah, I'm from the Saik'uz First Nation, and I have resided in the Stellat'en First Nation for 33 years. I am married to Robert Michelle, who is the current chief of the community. I'm very honored to be here and to be asked to give you a little bit of perspective on virtual care and how it has affected me, how I absolutely love it, and just some of the experiences that I've had. So I think we wanted to share a little bit about, I think, Richard, we were talking about my nephew.
Yes.
Is that, yes.
Yes, that's right.
So my nephew is 18 months old. I had gone to visit him just over a month ago. And when I had gone in, I was really shocked because his little face was just exploded with eczema. And he was blistering. It was quite terrible, and he was really suffering. You know, I know that there's a shortage of doctors in his community, and he lives in a really large First Nation community too, and some of them don't have the access. They didn't have the access of what we had in our community. So I know that there's still some communities that are not getting the virtual care like what we are getting. So anyways, I had gently asked my sister-in-law if I could please send a photo of my nephew to Dr. John Pavlich, and she immediately agreed. And so we did a little video of him, and I did a few photos, and I sent it to Dr. John. And Dr. John immediately, I was really surprised because it was late in the evening. It was like 7 o'clock in the evening, and he immediately answered me, and he said, "This child needs to go to Children's Hospital as soon as possible." And so we kind of went back and forth a little bit, just messaging each other. And Dr. John, I finally just phoned him, and he said, "Come to my office tomorrow. I'll be on the Stellat'en First Nation," which is about a good little over an hour's drive for my sister-in-law to get there. So we went in together to see Dr. John, and Dr. John immediately met and, kind of looked at the baby and introduced himself. And within minutes, he had already had something set up prior to speak with a specialist in Vancouver, a skin specialist. So this was on a Friday afternoon at 2 o'clock. And immediately the specialist, she said she was going to be in Telus, which is, if you know where Telus is, it's probably about a 7-hour drive from where we are. She said she was going to be in Telus, but she would be back into Vancouver by Tuesday evening if she could see the baby on Wednesday. So my sister-in-law flew to Vancouver, saw the specialist, was there she actually stayed the week, and they did some new creams, new everything with him, new prescriptions, and he was cleared up within days. And today his skin, I got a picture today, and his skin is just absolutely beautiful and smooth, and it's still a little bit red in patches, but it's definitely 100% better than what it was. And the poor little guy, he suffered so much. His entire body was so sore and itchy and burning all the time.
Okay, well, thank you for sharing that. And I know you've got to get going soon to a dinner. Is that right? I'm just wondering if you could tell us a little bit about the structure of the virtual care services there in your community,
Sure.
how people access it, and just sort of some of the impact that it's having, because I know you have a community health center there where you can access those virtual services. So you can tell us a little bit about that and how people in the community access it, and just very quickly the impact it's been able to have that virtual care option there.
Sure. Well, we have a beautiful community center, healthcare center in Stellat'en, and most of the communities now have a nice healthcare facility where we have the doctors come in. They can come in. Or we can do the virtual care, which I absolutely love. We can book an appointment. The doctors can send us a link to their room, and we can basically FaceTime them. Or we have the option to go right into the community center, have a nurse do intake on the patient, everything that's wrong with them. She can send that information to the doctor. The doctor will come in and we'll be sat in a room. It's kind of odd at first. Like the first time I did it was kind of awkward, but we were able to sit there and have the doctor come up on the TV, telehealth, and sit there and have a conversation. And explain to them what our concerns are, what our needs are, what if we were severely sick, or they were able to help us through it, or get us the tests we need without them having to be there. And most recently, I actually I got really sick, and I kind of hung it out, thought it was just a cold or it was allergies, and for about a week and a half I was so sick, and I finally gave in, and I sent an email to my doctor, and I asked if she could call me, and she phoned me, and she said no. She goes, we're gonna get you in for an X-ray in Birds Lake, which is, I had to drive 45 minutes to the next town because we don't have a lot of the services in our town. So I drove there, and by that afternoon she said, you have pneumonia. So it was great, and she already had a prescription waiting for me. So by the time my husband was able just to run to town and grab the prescription, and I was on the way to getting better.
Wow, that's amazing. Thank you so much for sharing that. I understand you've got to go. If you can stick around a little bit, that's great. But I understand if you need to leave us, I'm going to welcome our other guest speakers here. But thank you so much for sharing that perspective, yes. And we'll make sure that's part of the conversation going forward. Thank you. Wonderful to have a perspective from a patient and someone who lives in a rural community to add value to this conversation. I know we'll talk a little bit more about that. But let's move in and welcome the three of you here. And Birinder, I'd like to start with you. You know all about what British Columbia has here, which is a digital health strategy that has been laid out by the province. And I was wondering if you could tell us a little bit about the vision that strategy has and where virtual services fit into that vision.
Sure.
Yeah, absolutely.
I don't really need it,
I know.
just for recording purposes.
Yeah.
I was told I shouldn't start by saying I know nothing, so I know not nothing. So one of my roles that I have done on top of being family physician is I've been the board chair for the Burnaby Division of Family Practice for the last couple of years until this week, where I stepped back to be a father. But one of the work, some of the work we've been doing is on primary care networks, which I know what some of the other people are going to get into tomorrow. But a few years we've been looking at how do we build some virtual infrastructure to support some of these services we're trying to offer, because too often they don't exist. So we can have allied health resorts or more family physicians or more nurses or more receptionists, but if it's like in all these different systems that aren't talking to each other, it's just going to create more of a headache. There's data out there that shows that what physicians spend about 40 minutes to 1 hour a day just chasing information. Like, it's 2023, we're chasing information, and most of that information's on paper somewhere, or faxed or scanned in and then labeled wrong, and there's no like searchable, secure way to access it. So that's just one example, but what the province is looking at is we have, different health authorities that use different clinical information systems. We have the community providers, whether they're specialists or family physicians, nurse practitioners, midwives, registered nurses, whoever's doing whatever work they're doing. And there's over 30 electronic record systems in the community, and they don't talk to each other. And so the province is, and that frustrates us, but I'm sure it frustrates you a hell of a lot more too. And so how do we reduce that burden? I think that's the underpinning of what the province is looking at right now, which is how do we make you as a patient, you know what your health data is, and have that data follow you at different points within the system, and in a way that is protected. And so that is the work that's being undergone right now, and that's going to be looking at, there's some work in the north being done on a personal health record, so that's part of it. There's part of it is looking at how do we do digital referrals. How many of you have had a referral sent and then you don't know what the hell's happened to that referral? Yeah, exactly, right? Or a family member. It's like, and then you're having to like call someone and they're like, oh, well, we didn't receive it, get them to send it again. And they're like, well, we did send it, okay, but now that it's expired. And you're still going back to faxing, right? It's like the bane of our existence, and it wastes every time, frustrates you, and makes people lose confidence in the system. So one of the big parts of it will be looking how do we enable digital referrals in this province securely. So if I send Dr. Mitra a referral about one of my patients, her clinic will get notified of the referral, patient will get notified of the referral as well. If once an appointment is booked, you'll get notified. So that there's this closing the loop of communication through the process. So that's one part of it. And then, we need to work on, we keep talking about terms like interoperability. What does interoperability mean? It means that if I'm using one system and one of the other physicians using another system, and we need to communicate, or if I need to switch my system to their system, that your patient data is able to be ported over in a way that is effective, not cost prohibitive, and in a standardized format, so that we can let competition in the marketplace thrive, but we don't have to worry about what's happening to your data in the process. So that's some of the work that's happening. It's going to be a lot, and it's going to take time, but there's some really motivated people behind it. There's a lot of political interest in it right now. So when there's political interest, that means there's funding with it. And so when there's funding with it, stuff can happen. So hopefully it makes a difference.
All right.
Yeah.
And we'll circle back in a little bit and maybe talk a little bit about where the next level of impact can be made. And I think that might speak to what the members want to discuss. But let me introduce Keir next with Telus Health. Quick show of hands, who's used Telus Health services, virtual care in any way? All right, some, not a lot. Keir, maybe let that be part of your introduction, but can you tell us a little bit about what...
Six words.
In 6 words, what Telus Health does and kind of the role it occupies in this space and maybe how it got here.
Perfect, thank you. Yes, I did say that I could introduce myself in 6 words, and
you're done.
I'm already, yeah.
Thank you!
I'll just maybe run on sentences, run on words. I don't know if that will help me. Maybe I can talk a bit about what I mean. Telus Health, obviously, large organization, large number of clinicians who support the organization, and we offer a range of services. Maybe I can just speak to one of them and why I am excited about virtual care and the types of services that we offer. So my clinical background is in emergency medicine. I worked for 11 years in Edmonton, in the emergency department in downtown Edmonton, and for a couple of years in Victoria at both the Jubilee and the General Hospitals there. And I would say one of the most difficult parts of that work was less around the extremely ill folks that we would care for, although that was obviously difficult work. It was seeing folks sitting in plastic chairs for 4 hours, 6 hours, 8 hours for non-emergency concerns who weren't there because that seemed like the best place to spend their Friday or Saturday night. It was because they had no other options. They didn't have a family doctor, their doctor's office was closed, there were no walk-ins taking new patients, even in places like Victoria. And so to me, the work that I do now with Telus Health, my excitement about technologies like virtual care is really about accessibility. It's about giving people options. It's about helping folks who don't have a family physician or who struggle to access a family physician or nurse practitioner use technology to get care in the comfort of their own homes at the time and the place of their choosing. And that is how I explain my transition from being a full-time emerg physician to someone who now works at Telus Health.
Okay. Thanks very much. We'll get a chance to come back with some questions about that. But Lindsay, I wanted to turn to you next. I know you in your lab, you've studied a lot of virtual services here and around the world. You've seen what works well, what doesn't work well. What are we doing well here in British Columbia, and what are we not doing well?
Do you want to
I don't know if that one works for you or that one.
This one works. Okay, so Maybe before I get into that, if I may, I'll just provide a tiny, tiny bit of background, which is to say, I've been studying physician shortage and primary care shortages in this province for going on 15 years now. We have more primary care physicians in BC per capita than ever before, and so there's so much conversation for years for trying to understand what is driving this experience of shortage. If we have more physicians providing services, why are our patients not able to access care? And virtual care was not on my radar. It was not a thing that I really studied much, and the reason for that is because Canada is so far behind most OECD countries in terms of our use of virtual technologies. Prior to the pandemic, something like only 5% of family physicians in this province were routinely using phone or video to communicate with their patients. And in other places like in the US, in the UK, those types of visits were very much commonplace. They were integrated into regular primary care long before the pandemic. But when the pandemic hit in 2020, it was like a snap of the fingers, where all of a sudden physicians were like, we need to be able to continue to provide care for our patients in a way that is safe and minimizes infection risk for us, for our staff, for our families, and for our patients. And so it was like this complete change overnight in terms of how physicians and other healthcare providers were providing care for their patients. And so I sort of changed the lens with which I was approaching my own research program and started to look at all of these questions around virtual care. And since that time, we've run a number of different studies that look at the ways that clinicians are integrating virtual care into their practices, that ask them about their experiences in delivering virtual care, and working with patients to ask them about what's worked well for them and what hasn't worked well for them. So I'll give you like the Coles Notes version of what we've learned sort of over the last, I guess we're now sort of three-ish years in. So the first thing that we've learned is that for physicians, this transition into virtual care represented a pretty tricky time in their clinical lives. It was associated with a lot of extra burden for them in terms of doing work. They were suddenly faced with having to work with all of these technologies that they weren't necessarily familiar with in the past. They weren't sure which patients, which services were suitable in that virtual space and which ones weren't. So it was a totally different way of providing care. And the decision around when is it appropriate for me to see my patient depended so heavily on the particular needs of that patient, and very, very importantly, the specific relationship that that clinician had with that patient. That longitudinal relationship was so critical in terms of them being able to make a decision about, is it appropriate for me to see this person virtually, or do I need to bring them in? So what we heard is that there are some patients for whom this transition to virtual care really did actually improve their access. So people that don't have to take time away from work, that don't have to access childcare because they can do a 15-minute phone call with their clinician from home, that's been a huge improvement. We heard from physicians that people are taking more sort of incentive to do preventative care with their health, I think probably because of the fact that it's so much more convenient. We had one clinician who told us that suddenly they're seeing all of these 40-year-old men whose fathers may have had heart disease issues, who never would have come to see them to talk about preventative care, suddenly taking 15 minutes out of their day to have that visit. So that sort of ownership of health was a big piece. But we also heard that it has created a lot of access issues for other patients. So I was excited to hear Gladys' story where she was talking about the fact that there was a space created for her to go into that clinic and conduct that visit. There are a lot of patient groups that don't have access to a cell phone, that don't have access to a safe and private space where they can navigate that virtual visit. And so for them, in a system where suddenly virtual care had become dominant, they were faced with much poorer access than they had even before. So maybe I'll stop at the access part, because that was a lot as it was, but happy to address more questions.
Well, no, and I think that actually is a great segue into, I think, some of the questions we're gonna see from our members here, which is about getting us over the barriers that we've identified. And I think you've all kind of brought us up a little bit to speed about what we're doing right now. And I know this panel sees itself as empowered to figure out what barriers we can overcome, what we can do next. And I'd be glad to get your guidance as you answer the questions on the points where we're really stuck. And you brought up issues about data interoperability and data sharing, obviously data privacy, very important, and obviously a lot of these concerns around technology, both not only from a patient perspective, but interesting to hear about how it affects doctors and nurse practitioners and other primary caregivers as well, that there's a technology possible barrier there. So our members are gathered here with a keen eye on being a part of coming up with and identifying potential solutions and want to know a lot about what's in the way. So I'm going to turn over to you guys now to ask some questions and just ask our guests up here to be extra mindful around and be blunt as well about what we need to do, what steps we need to take in order to kind of get us where we need to be with integrating virtual services better. There's a microphone. I'm just going to walk around with this microphone, although many of you have already shown us that you can project your voices pretty well. So if you don't need a microphone, just wave me off, but wave me forward if you want one. And Abby's getting the next one started right there. Maybe I'll leave this one with you then, Birinder.
We can probably share one if you want to take one around. Yeah,
okay.
yeah.
I'll just lean to either side.
That's okay.
Wonderful. So can I invite the question? Yes, Ruby, over here.
One of our most handicapped, I'm sorry, I have trouble with words. One of the groups of people that are hardest to reach are homeless people. How would you suggest we go about providing virtual care for them?
So I could talk a bit. I talked a bit about digital health, but my day-to-day work, like I said, is at Reach Community Health Center, and so I have a lot of patients who have housing insecurity, and we do opioid agonist therapy and hormone therapy for transgender care. So when COVID hit, clinics were shutting down left, right, and center, and we didn't close a single day because we couldn't, because our patients don't have phones. And so we had to learn how do we implement technological changes, but also keep that human connection. And I think part of when we look at virtual care or any technological solution, it has to answer the question, what is an unmet need and how can that complement the in-person care that's being delivered? And so the answer to your question is there needs to be a relationship with someone that they trust. Whether that's in person or virtual, there's still a person on the other side. And I think establishing a framework and infrastructure to support relationship, when a patient trusts you, they will figure out how to connect with you. I have patients that will do all sorts of ways. I have a phone for an hour, call me on this number, or I have an email of someone who I'm going to be staying with, and they'll make themselves available, accessible, if they feel it's safe to do that. And I know it sounds a bit grandstanding, but sometimes it's just trust. So one of my mentors said, "What is family medicine? It's complexity in relationships," and so housing insecurity, opioid use disorder is the epitome of complexity in what we're facing today. So I really think that we need to show, how do we develop relationships? Is understanding, thoughtful communication, creating some cultural safety, practicing anti-racism, in your day-to-day practices. And when we look at technology, are we using those same parameters to protect the patient? Because if we have virtual care solutions that are only being accessed by the same people who have family physicians who are living in the richest areas and are doing it at a convenience, that's not I don't think that's the right way to use that. It should be complementary to a system that exists. Yeah.
Yeah, go ahead.
Just to add to that, because I think that was an absolutely fabulous answer, Birinder. So one of the things that we have learned in some of our studies working with individuals who have opioid use disorder and face issues around housing insecurity is that partnerships with community organizations are really, really powerful. So you can have groups like shelters or community centers that are able to offer up spaces that are private and that have access to a phone or computer so that someone can come in and conduct a visit virtually with their clinician if it's difficult for them to go in person. I also just want to say decision-making around virtual versus in-person needs to be patient-centered in all ways, which means that every patient, regardless of their situation, should have a say in whether the visit is happening, virtually or in person. And yes, there are certain types of medical visits where it's just not really appropriate to do virtually. There are certain things like physical exams, for example, that have to be done in person. But we would not want to deny a person who is dealing with housing insecurity a virtual visit because they don't have access to a space. So I think some investment into community spaces that will allow individuals who don't have a safe and private space to conduct a virtual visit to go and have a time where they can have their visit with their clinician in that community space is another place where we could sort of move forward to make some improvements in access.
I just want to start by saying I really appreciate the question, and also both of the previous answers I think are phenomenal. This may sound strange coming from someone who works for a health technology company. I think part of the answer to your question is that technology is not the right answer all of the time for all patients, for all problems. While I think virtual care is an immensely powerful tool, and of course, to Lindsay's point, should absolutely be an option that is presented to all of our patients when appropriate. I think there are other times when in-person care is more appropriate. And to the example that you raise on the Telus Health side, we may be more known for services like MyCare, formerly Babylon by Telus Health, which is a virtual care service. But some of the work that we do actually involves partnering with community groups in mobile health vans who are going out to reach folks who probably would not be accessing other services and would not be accessing services, to your point, from clinicians that they don't have a relationship with. So again, I think it's part of what excites me about Get It To You, is not just focus on the technology side, but also on things like mobile outreach to hard to reach communities.
Meeting people where they're at, right?
Yep.
All right. Yeah, go ahead, please.
I'll take a mic
You'll
just so
take a
everyone can
mic.
hear me around the room. So Birinder, you kind of spoke to my heart and soul earlier about electronic medical records. So,
I do that all the time.
So I'm not always the thing you're doing, right? So I'm a clinical social worker at Vancouver General Hospital, and it drives me absolutely nuts when someone comes in from around the province and I can't access their health records. Especially if I'm trying to investigate like adult guardianship, or there's like mental health things going on, or lots of long-standing issues.
You know the information's out there somewhere.
It's somewhere, but I don't know where it is because it's in some different system that I can't communicate with. It's not in Care Connect, which is where a lot of different kind of health records can feed into, but not everyone takes part in it. So I look through Cerner, I look through like Paris, I look through all these records. I'm like, where is like this MMSE score? Where is like this diagnosis? Where is like this answer, that answer? So to finally get to the question, what is so hard about just putting us all onto one system so that both for me as someone treating the patient, looking after them and trying to get all this information, I can easily get it, and for all of us as patients, we don't have to like bring a binder of all of our medical records to whoever we're going to. They can just access it easily.
Sure. And someone else can add that, but I guess I should probably say something. No, I feel your pain, and thank you. I imagine your work would be immensely easier if you had access to information.
So much easier.
The single solution has been tried in places and often does not work because no single solution can adapt to whatever scenario it needs to. So you work at VGH, you get on Cerner now, like but they have like they have community records. I haven't played with it, but from what I understand, it's quite limited in functionality of what would be useful from a primary care perspective. And so, and also we're looking at a place where there are lots of vendors within the space, all that have attractive solutions. So to me, it's not. I think that when there have been communities that have tried to push for a single solution, there's been a lot of pushback from people who, for some reason, are not able to learn it. So there might be a technological gap. There might be, well, I don't like that interface, I'm just going to go buy this other one. Or there's people that say, well, that doesn't really fit our need, and that vendor's not really to like kind of work on that solution that could fit this need well. And so that's where we look at, okay, at a higher level, what is like the standard of information sharing so that should exist so that you could find that information no matter what system you're using. Or if your patient's there in front of you, like, okay, well, if I go onto a Care Connect, it's going to pull in all the things. The limitations of Care Connect is like, I use it all day, every day, and I would, like, it makes my life a hell of a lot easier. But I see things on there every day where I was like, well, I wish I could change that because that's just wrong. And I know my patients. And so a viewer, a unidirectional viewer is also limited no matter who it is. So it's like, how do you have rights established for some provincial system so that if you have something, you're a social worker, you're like, I can give valuable information that that next provider that sees this patient inevitably will find that useful and they know where to look. Or if I'm like a family doctor, okay, well that allergy is wrong, I know that because I remember that happened there, I should be able to fix that, and that burden shouldn't be on the patient to try to remember everything or print it in their binder. And so I don't think a single solution will ever work in this province from all the complexities that exist in relationships, and people might not agree with me. I think creating an environment where, that's why I said kind of a competitive marketplace, because I think, that's what we have, and there's not enough within public infrastructure to support the needs of patients, whether it's technological or, physical. So it's how do we look at strategic partnerships that actually protect patient data, but utilizes the strength of what someone else in this, like what you guys do, right? You guys have incredible tech. So it's like we should be looking at how can that help patients in the province navigate the system, but also like how is that protecting your data and how are we talking to each other in a secure way? Does that kind of address it at all, or?
It leads to like, it's not a one shoe fits everyone's foot kind of thing. Like I understand that. Yeah. I just think like all the doctors, you're all doctors, like you're doing doctor things, treating patients. Like
I do a lot of non-doctor things because I can't find information. So
there's only a few ways to write a note. Like at least to see the note in general. Like even if Care-Connect was like the unifying solution, just not everyone feeds into it is kind of what I get.
It gets piecemeal, and part of it is like if my patient sees someone down the street for a sore throat and it's completely benign, does that need to be in a provincial record? I don't know. But if they have a heart attack somewhere, I definitely want to know that information. So it is like decision rules on the type of data, how granular does it need to be, and who makes that decision? Is it the patient? Is it the provider? Probably a collaboration.
Yeah.
I would agree. I mean, there is too much data. There's all the time when I'm looking for the records and I'm like, well, this note was useless, this note was useless, this note was useless, this just wasted 5 minutes of my time. So I do see the trouble with like, you can't just put everything in there, but at least put a few more things in there for me to find.
I think it is for especially the key things that enable us to be able to do our jobs better. And I think that's the work, like any type of technical solution needs to have some kind of governance or steering direction in that to address these types of questions. And then it's like, is that table powered enough to make sure it's representative of patient populations? Mm-hmm. That's community governance, right?
Yeah. And so that if we're going to have a piecemeal system, how do we steward it well? Does that speak a little bit to your experience too?
It does a bit. So my other sort of teaching hat is I teach like historical policy of the Canadian healthcare system. So part of the reason it took us so long to get into a virtual care space is because of these, what I teach my students is they're called historical policy legacy. So it's the long tail, the impact of decisions that we made 30, 40, 50, 60 years ago that are now the foundation of our system and basically can't be changed, or like you could change it, but it would be extremely politically difficult to try and change it. So for example, one of those decisions is the fact that community-based physicians are independent small business owners by and large, right? Which means that they have authority over making the decision about which electronic medical system they want to use, if any. And I think if any.
My God.
Well, there are still some.
I'm getting palpitations now.
Sorry. And I don't mean to be disparaging in any sense to either of my physician colleagues here, but physicians make decisions around what electronic medical record system works best for them and their specific patient population needs, right? And what works for them best might, as sort of what Birinder said, might not work best for another clinician with a different patient population. So I think Birinder is absolutely correct in that we are unlikely to ever get to a place where there's a single unified input system that makes sense and work for everyone. And so the real solutions lie working on the back end to try to figure out how to get the right data out of those systems into something that is functional for everyone, but also that is patient owned, so that patients can access the data that they need and that they can see on a day-to-day basis, not just clinicians like yourself.
Contextualized.
There you go.
If it's not contextualized, it's just going to scare the hell out of everyone. If you see a red dot on something, you get scared.
Just to top up briefly, 3 things, I think, hopefully only 3. One,
6 words.
I hear your pain. As a one-time practicing clinician, I really feel for patients who would come to the emergency department and say it's in my chart or it's in my record, and I would say there is no record.
Don't you have it, Doc?
That was one of many ways that I would subsequently hopefully not disappoint them throughout their encounter. But yeah, it's not good, and I agree with you that it's not good. I think one international example, and then a Telus example. On the international side, I think if we look at the NHS, there is more than one EMR. I believe there are 4 to 6 authorized EMRs. They have to speak to each other. So I think there's a model for us there in terms of what we work here. I think another part of the solution that I think both my colleagues have referenced is around patient empowerment and patients accessing their information. So one of the things that I am most proud of on the Telus Health MyCare side is from the moment we launched, patients have access in the app to all of their records. It doesn't matter where in the province they are, it doesn't matter which clinician they see, it doesn't matter if they go to Alberta or Ontario, that information follows them and they have full access to it. And I think, again, that does not solve the entirety of this problem, but I do think it's an important component.
Okay. Good, more hands coming up. I saw one in the back shoot up first, so please go ahead.
Hi. All right, I'm speaking loud. I just wanted to kind of touch on that point a little bit. I recently had a medical health issue. I went to emergency care with severe pain, and I had a CT scan done, and it shows up on no records. I can't find any history of this particular record. I then went to my nurse practitioner, my family doctor situation, and said, like, hey, I would really like to get the results of the scan that I had done when I was in the hospital. And they went, great, we'll have to get you to fill out all of these forms. We then need these forms to be sent to the hospital that you just went to. And maybe we'll get results. And then when you get them, you have to come back to our clinic, hopefully get an appointment, and then you can get the results of the scan that I had done several weeks ago at this point. And again, I was in emergency care because I was in so much pain I could hardly breathe. So I would like to know a little bit more about like the lack of access that I have to my own personal health records. Like even if I wanted to be able to build a binder at this current point in my life, I can't. I have no access to these things. So just kind of like looking to have a better understanding of like, again,
I can start with
Could I ask one of you to speak to that, and then we'll get to some other questions as well?
I can speak briefly to, so I'm sorry, that sucks and that should happen to no one. When a scan, and this is the power of a few things that do exist. So we talked about Carrier-Sekani as an example. That solution, if you came into our office, we would have it up and print that scan for you. But if they can't find it on any system, that's like whoever registered your scan messed up something. So we can't change that. Like that means that record's basically lost. I don't know how anyone would find it unless they know the exact time, exact scanner you're in. It's like, oh, we put your name in wrong. But if that record exists, you should not have to go through that. And an alternate way that is coming up is through the Health Gateway app that has been developed. So they are starting to port more information into that now. So labs are going to be accessible in there, or are already. Anytime you encounter a healthcare system, it'll tell you kind of where you were, who you saw. Immunization records are in there now. And I think imaging is going to become accessible too. So some of the information from Care Connect is coming into there. Now, other parts they're looking at is, let's say you see a specialist. That specialist will be able to forward a copy of their consult to you, and then that would be available on Health Gateway. Now, again, that's decision rules. I don't know how they've decided how that's going to happen, what case scenarios, case situations, but there is work coming in. The problem is that's still coming in PDF format where you're just viewing a PDF. So there's still some work to do on how we actually digitalize that data to make it meaningful, but at least there's a viewer where people can see it. And that's where I must remind people, if you see red in your labs, it doesn't always mean bad. Because that's what happens. And it's like, my RBCs were 0.52 or my hemoglobin was 112 and it said it should be 115. We'll get those calls like, why didn't you tell me about that? And we'll say, no, that's actually not concerning. So this is what I mean about contextualizing data. I don't think it's ever good practice to say no news is good no news is good news, because that doesn't help you out at all. But it also means, like, how do we use, again, synchronous care, asynchronous care, which means I'm not talking to you, but I'm seeing your result. I can send you a message that says, hey, not worried about your blood test, let's talk in a few weeks, make an appointment, but no red flags. That at least helps reduce some of that anxiety in the time. And I have to review that lab result, so like it can happen while I'm reviewing that. So that there are things happening like that. Scaling it up in a way that patients have an equitable access to these technologies, independent of where they're being seen, is still what's quite tricky in this province. Yes, please.
Yeah. Just really quickly, hopefully for me. The first thing I'd say is like that is horribly unacceptable. The second I would say is, you know, in preparation for coming here, one of the questions that Richard kindly sent us was around, you know, what's not working in the system today, maybe even why are some things not working. My sense, having been around the healthcare space now for about 20 years, is that we built systems around physicians and hospitals. And it is convenient for the physician and the hospital that you don't have immediate access to your record, or that you have to fill in some forms, wait in a line, go somewhere, wait 6 days, go somewhere else, and stand on your head and yodel, and then someone will give you your medical records. But that's insane. It should be on your phone or in your hand the moment it's been dictated. You know, I think one of the other questions, you know, what is the role of companies like Telus in the healthcare space? Interesting question. I'm sure there can be lots of debate about, you know, what do we want companies doing in this space? For me, one of the answers there is showing what can be done when we really put the emphasis on patients, on customers, on clients. And again, to sort of obsessively go back to the MyCare app, there was no committee or focus group or panel assembled around, do we want patients to have access to their records? It was a really easy decision. We had a group of folks in a room, patients, clinicians, et cetera, and it just seemed like the obvious choice. And to me, you having access to that scan, and the moment it's been dictated, is the obvious choice. And things we do to make that more difficult, I think need to go away as quickly as they can.
Lindsay, did you want to add to this as well?
I
know
think
this
that's
is-
pretty complete. I'll just
Okay.
echo and say that's really terrible, and I'm sorry that you had that experience. It's not acceptable.
Okay. Jane, and then the hand I saw over here.
I think
And then I'll look this way.
Well,
Yes.
yell. You know, I'm having trouble formulating this question, but I have a question. And it's somewhat germane to what you're talking, I think it's very germane to what you're talking about, and it's about technology. And who they is. Who they is who makes decisions about technology in this country. Somebody here mentioned the F word, facts.
Oh, God.
I have.
I'm like, I haven't sworn yet.
Issue with facts. For many, many years, I owned a dental laboratory here in Vancouver, and I regularly received erroneous faxes. My phone number, my business number may have been similar to VGH, maybe, but I received really sensitive information. And when I would call and say, you dialed wrong to fax, well, this is the secure way to send it. And I'd think, are they insane? I mean, are we saying we need to go back to rotary phones because they were the safest way to dial a number? So you're talking technology, yet I still have to call Costco to see if they got a fax and if someone read it. And then they didn't, and then you go back, and did you send the fax? We'll resend the fax. It could have gone to anybody, who knows? Why are we still dealing with fax, and you're talking about technology, where we're supposed to be and where we're going? Who is they who's decided that this is the safest, most secure way to send information, where it's ludicrous, and it's like the emperor with no clothes. Everyone knows it's ludicrous, but they still keep saying, we cannot send an email that's secure. Bullshit. We do it all the time. Can somebody talk about how we got to this point where there's such a diversion in ideas and where common sense went?
Thank you. And maybe to add to that, not only who are they, but how can we stop them?
Yeah.
That's the question.
So who are they?
I think it was Tara. Direct your questions to her, please.
Stop looking at me. Okay, I can try. Oh, you've got one here, sorry. Oh, God, the fax machine. Okay, so I think this again comes back to the history of how we structured our system and who is responsible for what and who can push people to do what and where the money flows from A to B, right? So again, if you have a private business, a private physician's office that decides it's easier for me to still use fax, I don't want to make the transition to email, not going to make the transition to email. Some of our older physician colleagues in particular, again, no offense meant, still rely more heavily on fax because they're not comfortable working. Yeah, I'm talking about you. Are just not comfortable working in that email space. So that's part of it. The other part of it is then there are sort of systems that are built up around the use of things like fax. So there's a process that follows the use of that fax. And so when you talk about let's get rid of the fax and switch to email, it's not just the simple nature of, okay, I'm now going to scan this thing and send it in by email. It's the 17 steps that you have to take to get to that point and changing all of the different actors and all of the different things that have to happen to that. So it's not a simple switch back and forth. I think the other part is just the way that our system is siloed. So everyone has responsibilities that fit within a sort of single little silo that don't necessarily cross over outside of their own work. So it's like, I'm going to keep my head down, I'm going to do what I'm going to do, and I'm not going to make a change to the benefit of someone else. So if fax is working for me, if fax is working for the hospital unit that I'm responsible for, I'm going to stick to it. I think to your point, my argument, and to be completely clear, I'm not some expert in terms of how internet security works. To my mind, email would be more secure than fax for some of the reasons that you just mentioned. We do so much of our banking these days electronically, and we're all comfortable with that. We're comfortable with doing e-transfers. I just signed new mortgage forms. Everyone should feel sorry for me because the interest rates are so terrible right now. I just signed new mortgage forms this month electronically, right? So we're all comfortable with that. So to me, it's not about the transfer of information and the privacy risk there. It's about the fact that making any kind of big change is very difficult, whether you're talking, and again, there isn't a sort of top-down structure that we can use to say, everybody has to do this now. The way that we've structured our system, it would be like government saying, all of these small businesses that all exist, I am deciding as government that none of you can use fax anymore. Telling the health authorities, telling the individual community-based physician practices, nope, we're not going to use fax anymore. It would never fly, right? Because theoretically, that's not government's role in that case because they are private small business owners. So that was a lot. Hopefully I at least covered a little bit of what you were trying to get at.
I can just say I don't understand it either, and I feel like it should be government's role. I would love there to be a province-wide announcement saying effective this date, no one can use faxes. I believe the NHS did it. I think we can do it. Faxes. We're on the same page.
I've just got a couple of things. So, agree with everything that's been said. Digital transformation is hard. Only 30% of digital transformation projects are successful. And healthcare is notoriously one of the hardest ones because it's one of the riskiest. You're looking at patients' healthcare data that there's so much identifiable information in there, so it's very prone to hacking, very prone to security risks. And I absolutely agree, faxes are not secure. But and in COVID, our digital transformation was enabling e-fax, which is like allowing me to send a fax for my prescription, which is like ludicrous. You look at other provinces, there's solutions called Prescribe It, which is electronic prescribing, and BC is refusing to adopt that because there's a West Coast elitism that exists in BC. That we want to use our own system and not look at what's being used in other provinces. So there needs to be political pressure from the public because that's how stuff changes. You look at the family practice issues last year. The family practice only got an investment because the public got involved. And so if we're looking at digital transformation, if public demand it, government will invest in it. And I think Keir is right when he says that it is the responsibility whenever there's a process that needs to happen for public services. It has to go through a public procurement process. And so it should be public procurement for healthcare means killing fax. And if a solution is presented, how is it going to do that? And so that is one way that they are looking at that as part of the stuff I talked about. So definitely that is on everyone's radar. And securely logging into it without remembering all these different passwords is part of it as well too. We know as people who have more tech, what kind of single sign-on technologies are. The problem with email, by the way, is email is very prone to hacking as well. So most email is not secure, so it actually make you more vulnerable. And so that's a whole other side of it too. So if your doctor is using email, make sure they're using secure email.
Birinder, can I ask a quick question to follow up? So I'm just curious. Yeah, forgive a maybe slightly pointy question. How do you think doctors of BC would respond if ministry was to come down and say, from now on, no one is allowed to use fax, everyone has to adopt secure email to do X, Y, Z, like, end of discussion?
The doctors of BC would say pay us for it and pay for change management and follow up with infrastructure and follow through and do not kill pilots that are being successful because you don't understand what's happening.
Do you think ministry would respond to that? Or do you,
The ministry would respond to the public, not to the doctors of BC.
Yeah, that's fair, okay. Just
Sorry.
curious.
BC is the place where pilots thrive and then die because there's no follow through. And there's no investment in change management.
I think pilots, a lot of the time here they stay, and the ministry will continue to fund them, but they don't scale them. So they'll evaluate and say, you know, so here's a perfect example. We have population-based funding clinics in BC. There are 9 of them. So these are clinics where physicians are paid not on a fee-for-service basis. They're instead paid based on the makeup of their patient population on an annual basis. So we have 9 that exist across the province. They've been evaluated. They work pretty well. Do we have more than 9? No, we still have 9. It's been like 20 years. Those 9 clinics still exist. The clinicians who work at them are happy. Their patients are happy. We still have 9 because the ministry doesn't put more money into scaling those innovations further. Community health centers are another great example of that.
I'm working at a clinic where our contract expired like 4 months ago and the Ministry of Health doesn't know how to pay us.
No, not surprised at all.
So I'll still go to work and see my patients, but I know I'm getting underpaid significantly to do it. So that's BC.
Yeah.
Okay, we're definitely getting to the heart of things right here now. I feel like, yeah, exactly. Now that we're getting a little bit.
It's all because of the facts. It really is the facts.
As we got a little bit of later start off, we can just kind of keep things
please.
going a little bit, and I'd love to take at least 2 more questions. I promised to look this side of the room first and then that side. So did I miss one over here? All right, I'm going to go right there to Sabrina. Do you want a microphone?
No, I think you could probably hear me in Nova Scotia from here. My question has to do with basically security and ease for different demographics. So for like older folks who are not comfortable with technology, like they can use a telephone, just dial somebody, maybe send a quick message, but to do anything virtually, they need help. What happens when they can't get the virtual part of it so that it can actually talk to a person virtually? How is there not like a button that they can tap so that somebody can talk them through the steps of actually doing the virtual meeting, as well as for groups who are people who are on receiving end of abuse, sexual abuse, trans groups, people who are not comfortable going into an office and are scared that somebody in their life, if they found out that they were trying to do something virtually, could harm them further. I know that there are outreach platforms that if you are using them and they hear that someone that could cause them harm is near, they can push a button, it becomes a benign screen. Is that something that healthcare providers are more looking into of an ease and access as well as a kind of quick drop away so that a person has that security in their own space?
I can speak to the first part of that, and then maybe I'll pass it to the other members of the panel to go with the second part. So the elderly in particular is a patient population that came up a lot when we were interviewing physicians about their experiences in providing virtual care. And one of the messages we heard was actually it didn't end up being as bad as they thought it was going to be. They really anticipated that it was going to be very difficult for some of their patients to be able to navigate these virtual systems. But I think the reason that it ended up not being as bad as they thought is because the vast majority of physicians in BC very rapidly at the beginning of the pandemic switched from video to phone visits. So something like 90+% of the people that we spoke to were like, no, you know, we did like 2 or 3 visits by phone and found it was just too difficult for our staff to navigate, too difficult for us to navigate, too difficult for our patients to navigate, really difficult in terms of internet access where places don't have sort of stable internet. Phone is just easier. And you know, elderly patients can navigate a phone call just fine. And so that was sort of their foray into virtual care. In places where video was still necessary, one of the things we heard over and over again was the importance of family caregivers being present to help that person navigate in that virtual space, which is, I mean, it's great, but it speaks to the importance of the role of unpaid caregiving as part of our society, and the fact that we can't always depend on that person being there, and that that's an important role that they're playing. So I guess first easy answer is mostly it's been phone, so it hasn't been bad, and then the second being making sure that there's a support in place when it has to be video for that patient to be able to navigate the system.
All right. Can I invite another one? Yes.
All right. So I have used virtual care. I've been very pleased with it. It's been nice and smooth. I appreciate having it in my life. But having said that, I did find a significant gap in it, in that I couldn't renew my ADHD medication. And I'm just wondering if anything, I assume that's not the only kind of medication that can't be renewed. There's probably other gaps between what virtual care can do versus what a doctor in an office can do. And I'm wondering what, if anything, is being done to address those gaps.
I have words by the necessary.
No, you should start.
Sure. Let me start. There's a few things. I think the first is there's actually some tie-ins, I think, to the previous questions. I think sometimes on the regulatory and funding side, we see rules or guidelines that actually unintentionally harm folks. So on the telephone versus video, for example, for older folks across the country, we see a number of provinces cutting back fees so that you earn less as a physician if you choose to use phone over video. We see other changes around, episodic care versus seeing your own doctor in places like Ontario, and fee differentials there. And I think, to your question specifically, we see guidelines or regulations times from the provincial medical colleges about what should and shouldn't be done in virtual care. And my belief is that wherever possible, that decision should be between the patient and the physician, because there is no way from a regulatory perspective for us to anticipate all of the unique circumstances, why you need the medication, why you don't have someone else you can see for the medication, what you're taking the medication for, what impact not having it is having on you. And so I think, again, there are well-intended guidelines or regulations put out, but my sense when it comes to things like virtual care is wherever possible, let's leave the decision to the patient and physician, let them have that conversation, and then make a decision about what is and isn't appropriate to prescribe. I will say on a positive note, and others can correct me if I'm wrong on this, I have seen some evolution on the regulatory side. Older versions of virtual care guidelines would talk about medication X can be prescribed, medication Y can't be prescribed. What I'm seeing now is a greater emphasis on relationship and continuity. So maybe I've never seen you before, maybe I'm willing to prescribe the medication for you today, but in exchange, I will make sure that you see me again in 2 weeks, 3 weeks, 4 weeks to let me know how things are going. And so by establishing that continuity, even if it is with a previously unknown virtual care provider, we make sure that you are safe and getting the appropriate care that you need. And that to me makes sense from a regulatory perspective. But a list of things I can and cannot do by virtual care, I think really misses the patient element in those cases.
Yeah, please go ahead.
I agree with everything that Keir said. I think that some of the parts of it is like that missing information piece too, is if I'm seeing you for medication that I haven't prescribed before, whether it's a stimulant or regulated or anything else, is I have, there's liability associated with that prescription, right? And so people might not be willing to take on the risk if they don't have the history, because out of fear of the regulatory bodies, because they might say, well, you didn't follow this, you prescribed an opiate, but you were doing it virtually, so you couldn't get a urine screen. And I'm like, well, I don't want to use a urine screen because I don't want to be punitive to my patients. I trust my patients. But the college will say they're protecting patients, but then instead they'll be putting up barriers to prescribing. So for one example, at REACH, we obviously do a lot of opiate prescriptions as part of our opiate agonist therapy, and the colleges audits our prescriptions. Instead of saying you're providing a service that we're delivering on recommendations, whether it's safe supply or opiate agonist therapy, then you target our medical director in the middle of a pandemic to audit the prescribing, to give feedback on it. So I think part of that is is there trust at different levels of the system? Do you trust in the relationship? Do you trust in the the skill in the physician that's prescribing, and you trust that the patient is not misusing the, there are people that will, we used to call pharmacy shopping, or going or prescribing, going to that. And so it's like having, I want to trust patients, but I need to have access to that as a safety, your information, like your prescribing history, where'd you get it from? So I know what worked for you, what didn't work for you. Is there risk for doing this for you? So there's a lot of different elements to it. But I think that with this information sharing part of it, I'm hoping that reduces some of those burdens. And actually, when we've been talking a lot about this, is how do you enable virtual health? All of this stuff is great theoretically, but unless the regulatory practices actually evolve to support things, you're not going to get a lot of adoptability because people are going to be scared. When Dr. Pham and her team talk about team-based care, one of my biggest worries about team-based care, we do it every day, is how do our individual colleges of regulatory bodies support team-based care without throwing anyone under the bus who's not the individual member?
Interesting.
Segue.
And a segue to tomorrow already for them here. I want to start my conclusion just by thanking all of you for being here, and if I could certainly summarize part of what you brought to us tonight is that change is hard, and yet we have a group of people who've come together to articulate what that change should be and to be in a position to advocate for it, kind of the political will and the public will that you spoke of and all have spoken a little bit. And also that change is complicated. It's felt like every time someone asked a question, we talked about an issue like how do we improve data portability and interoperability. Well, we also need to fix this issue of governance and of accountability and of infrastructure. And if we're going to sort of have overcome technological barriers that that Gladys talked about, well, we need to have more community centers and more places for people to go where they can access that. So the change is hard. And change is complicated. I want to ask each of you, if you can, just in your kind of final word to folks tonight, and I hope you'll stay afterward, is just to give us one last piece of advice about how to overcome, how to work hard to overcome these hard changes, and how to in the face of this complicated situation, how to actually articulate something that will make sense, and how to make use of the public will that is in this room right now. That, or throw a note of caution to people too. Who wants to start?
I have the mic.
You have the mic here.
May or may not be a good thing, so I will happily start. I really quickly just want to say thank you so much for having me here. Thank you for the phenomenal questions. I will very much happily stay afterwards if folks have any other questions, comments, or feedback for me. That's great too. I think my only parting words in terms of change, I think, is that your voice matters, and your voice needs to be heard. My personal belief is that as a physician, physician voices, again, physician convenience, physician interests very often dictate the way our healthcare system looks and functions, including things like the fact that it's hard to see a doctor on evenings and weekends. Doctors still use fax machines, etc. And I don't think that is going to get substantially better without all of your help, without your voice, without your input. And so again, thank you very much.
I'm not sure I have that much to add. That was really excellent. I think the idea of really sort of using your voices to advocate for a better system, because I think, the point's been made by both of my other panelists today about, what's going to make government make change. It's really when patients make noise about things being unacceptable. And I think the best way to do that is to really be as informed as you can about what is working in the system and what's really not. And so you can speak loudly and repeatedly about the change that you want to see happen, whether that is wanting to fight for better interoperability of electronic medical records so that you don't have to spend 6 hours at an ER trying to re-explain the same thing over and over again because they can't access your electronic medical record from your GP, or whether it's getting access to an after-hours appointment or getting access to your medication virtually. And I have the same situation. My son has ADHD, and it drives me nuts that I have to go see our GP in person I think it's every second visit, despite the fact that nothing has changed. So right there with you on that one. But really do use the education that you're getting through this process, and use your experience, your lived experience in accessing the healthcare system to raise your voice and demand better from our government.
Here, here. I don't know what to say. I guess we can give some platitudes. I mean, complex problems have complex solutions, but I think it's part of this is it's the discussion about facts is just one reminder of the current state of affairs. So you'll go on social medias or other industries, and you'll look at generative AI and what is the role of all these artificial intelligence in doing this and the potential for the future, and it's cool, but we're still using faxes. So I think part of this is with a digital health strategy, it's how do you inspire innovation in a practical stepwise fashion, knowing we're not going to get to generative AI helping us in ways to deliver care. That's miles away. There are certain things that technologies can support us with: administrative booking, reducing redundancies, all sorts of things. There's so many gaps that technology can support, but we need to look at how do we do this in a strategic, innovative way that represent public voice, has adequate governance and investment, so that even if there are small kind of failures along the way, it doesn't stop the momentum of what's needed. And I think it's what is the big picture strategy, and how do we actually start inspiring people to get there? And if they're not delivered, then absolutely your politicians should be accountable. And they're going to try and say, well, this is a federal issue, no, this is a municipal issue, this is a provincial issue, and be like, that's not my problem, that's your problem. Put it back on them.
All right, well, thank you very much. Again, for joining us tonight. It's a big part of obviously helping to make everyone here informed about these decisions and choices in front of us. I know you've all given up, your Friday night to be here with us. I know, Lindsay, it's your anniversary tonight. Happy anniversary. 15th anniversary. Yes, thank you very much. And Keir and Birinder, of course, with the new son at home. Thank you so much for being with us. Stick around.